Hi, and thanks for joining Provident's coding webinar series. Today we'll be highlighting the key IPPS and coding clinic changes that went into effect on October 1st of this year. I'm Ben Cyberborn, and here's a little background information about me. I have over 10 years of experience in HIM, inpatient coding and auditing, and clinical documentation improvement. First, we'll be going over the FY 2017 IPPS changes, first the diagnoses and then the procedures. And then we'll also go over some key coding clinic changes that occurred this year as well, and specifically clinical validation. So there's approximately 2,000 diagnosis codes added, 425 revised, and 311 deleted, with a new total of 71,486 codes. There's also about 4,000 procedure codes added. Most of them were cardiovascular and some orthopedic, so not a big change across the board, but really a focus on cardiovascular and orthopedics. There's 12 deleted and a new total of 75,789. So let's first go over the diagnosis changes. So I'm just going to go in order of the actual changes that happened in the coding guidelines. So just talking about this excludes one versus excludes two issue, where excludes one means you can't code two codes that they can't both happen. So for example, you can't have a congenital code and an acquired code, right? It has to be one or the other. And excludes two means you can code both of them. It means don't code it here, you can actually use two codes. So if you had a fracture on two parts of the leg, then you would code both codes. So what's this? So just here is an exception to that rule, and it doesn't happen often, but it makes sense once you go through an example. So here's one, code F45.8, other somatoform disorders. If you look there, it says that this code excludes sleep-related teeth grinding, G4763. So what happens if a patient had teeth grinding unspecified? That would be coded to F45.8, but also had sleep-related teeth grinding. So you can't have both, so that makes sense, where it's either you have teeth grinding or you have sleep-related teeth grinding. If it's more specific, then code G47.63. But what happens if a patient has psychogenic dysmenorrhea? That has nothing to do with teeth grinding, but that is included with code F45.8 because it's a general code. So this makes sense. So if a patient has both psychogenic dysmenorrhea and sleep-related teeth grinding, then you can actually code both. You would code both codes separately, and that would be an exclusions to this excludes one, which is very tricky. But the whole idea is it shouldn't happen too often, and you can use your judgment when it does occur. So here's one of the big changes that makes things a little easier for ICD-10. So now that terms that are listed with are automatically assumed. That wasn't always the case before. There was exceptions to this where even with the with term, there still needed to be documentation to link. So I'll give you some examples when we get later into the presentation. Bilateral conditions, where if a patient had say cataracts and they came in with cataracts in both eyes, and then one was treated on one admission and another one was treated in another admission, then you would only treat, if the previous treated site condition still exists, then it's appropriate to still find the bilateral codes. But now, so if a patient has bilateral cataracts, then you would code both. But then on a second admission, where if one was treated, then you would only code one side. I think that's just it's just a new rule, but it's pretty straightforward. What's big now, though, is there's new NIH stroke scale codes. So whenever that's documented, they can now be coded. So be on the lookout for the National Institute of Health stroke scale codes and documentation. We finally have a Zika virus code. So here's one of the big ones I was talking about where there's a link. Before, a patient with hypertension and heart disease, that needed to be linked. And you could not assume that a patient with heart disease and hypertension was that there was a cause and effect relationship. Now there is. All coders, one of the first things you learn about cause and effect and linking is, say if a patient had hypertension and CKD, you would automatically code them. So if they wrote CKD on one progress note and then hypertension on another, then they would automatically be linked. You would use the combination code. This is also now true for hypertension and heart disease. So this is going to be a big deal for patients, say, with hypertension and CHF. There would be an automatic link. Before, that was one of the big queries you'd have to make, and I've always heard mixed results with that. In talking to cardiologists, they would say, well, if they're on 3 antihypertensive medications, or if they had long-standing hypertension, or if their blood pressure was over a certain threshold, then it might be considered hypertensive heart disease. So now it's just, if a patient has hypertension and heart disease, then they're automatically linked. So I think that just makes things a lot easier. There's also new hypertension codes. So there's hypertensive crisis, urgency, and emergency. So physicians need to be aware of documenting these. Some of them are pretty good with it, but very important now that they should know that malignant and accelerated are no longer, they no longer have unique codes as they did in ICD-9. So if they document malignant or accelerated, it actually gets coded to unspecified. So actually, hypertensive crisis is a CC. Hypertensive urgency is not, and hypertensive emergency is. The tricky thing is hypertensive crisis is the umbrella term. So that's the general term of hypertensive crisis, and that's a CC. So if they don't further specify, then that's a CC. But we always seek best practice where we'd want them to specify, even if we lose a CC, where hypertensive urgency would be more specific, and emergency. And the big difference there is, so with hypertensive urgency, it's severe hypertension with a diastolic blood pressure over 120, but there's no evidence of acute end organ damage and/or there's little short-term risk. So if the patient comes in with a diastolic blood pressure above 120, and they can also have, and if they have headaches, shortness of breath, nosebleeds, so that would all fall into urgency. However, if there is evidence of end organ damage, like a stroke or loss of consciousness, heart attack, damage to eyes and kidneys, aortic dissection, then that would be considered hypertensive emergency. So pretty strict guidelines there, but definitely look out for that documentation and make sure appropriate codes are assigned. So here's a really big change. Pressure ulcer staging. Now it requires 2 codes if an ulcer progresses. So if a patient comes in with a stage 1 and it progresses to stage 2 on that admission, then 2 codes are needed. The first code would be coded as present on admission for the stage 1, but the second code for stage 2 would be coded as not present on admission. So this is a really big deal, and this is even more important to get the stage right on admission, because of course this will have adverse effects on quality scoring. So very important that all clinicians that are documenting pressure ulcers, so that's your nursing staff, wound care, some physicians that are looking at this, very important to get the stage right on admission, because if it progresses, and sometimes it's very difficult to prevent it, then it would be a strike against the facility for not being present on admission for the stage that has progressed to. For subsequent encounters, routine care of fractures, there's a 7th character assigned for routine care of fractures. So this is just a little more clarity on this, but not a major change. There's a new code for supervision of high-risk pregnancy. So codes from category 009, supervision of high-risk pregnancy, are intended for use only during the prenatal period. So for complications during the labor or delivery episode as a result of the high-risk pregnancy, assign an applicable complication code from Chapter 15. If there's no complications in a labor or delivery episode, assign code 080, encounter for full-term uncomplicated delivery. So a little change in language there from previous. Also delivery. When an OB patient is admitted and delivers during that admission, the condition that prompted admission should be sequenced as a principal. So this is always a question of like what should be as principal. It's so the guidance is to code the code for the complication. The delivery should be assigned as additional diagnosis. So really focus on the condition that was most related to the delivery. So most severe condition typically. This is a big change. This is something to really talk to your intensive care docs about. So usually, or in the past, the focus was on only using the Glasgow Coma Scale scores for traumas. So any patient that had a loss of consciousness then would assign that GCS code. But now the guidance is to also assign the GCS codes for non-traumatic conditions. So if a patient had a stroke, for example, and it was non-traumatic, then also assign the GCS codes. And this is very important because the GCS codes could actually be MCCs. So for example, if eye opening never or to pain, then that's an MCC. If the best verbal response is none or incomprehensible words, that's an MCC. If the best motor response is none or extension, that's an MCC. So, and it's also acceptable to use EMT documentation because those are the team that the clinicians who are really seeing that at first. And also, as the patient progresses, typically the GCS score improves, so you can assign multiple codes as per the guideline. So as mentioned before, the NIH stroke scale, there's new codes for that. So whenever the NIH stroke scale codes documentation is there, then it's acceptable for coding. They added a little more language to the 7th character. The idea for the 7th character A is for receiving active treatment for the condition, and D is for encounter of patient receiving active treatment and still receiving routine care. So this is another one of those things where it's not as intuitive as you think. So for patient, for poisoning, if the intent of the poisoning is unknown or unspecified, you would code that as intent as accidental intent. The undetermined intent is only for use if the documentation in the record specifies that intent cannot be determined. So the only time you can actually code undetermined is if they say it's undetermined. If there's no documentation or it's not clear, then it's coded as intent as accidental intent. So only use undetermined if they actually say the provider cannot figure out what was the cause. If they don't document anything, then it's assumed to be accidental. I thought this was interesting for outpatient. Anytime coding there was a new ICD-10 code for with or without abnormal findings, that was always a little tricky for me because I wasn't sure. So what happens if a patient comes in with, say, they have a long-standing hypertension and it's unchanged, and they're coming in for a well visit, but they have long-standing hypertension? Would you code that as well visit with abnormal finding for the hypertension, or is it only if they don't have any comorbidities, which would be very rare, I would say, from some of the elderly patients? So now this new language adds much needed clarity to that. So if a patient comes in for an exam with abnormal findings, this refers to the condition or diagnosis that is newly identified or a change in severity of a chronic condition. So that makes a lot of sense. Patient comes in with hypertension and it's unchanged, then that's considered normal. That's normal. You would not code abnormal findings. So if a patient comes in with for a well visit and they have hypertension and it has worsened, then you would code it as abnormal finding. Let's move over to the PCS changes. They just added an example here for multiple procedures. So if an excision of a lesion in ascending colon and excision of a lesion in the transverse colon, then it's coded separately. They just, the bold just shows that they added that example. There's a big change with how arteries are coded for bypass surgeries and PTCAs, angioplasties. So previously there was a focus on the actual sites rather than the arteries. So instead of thinking about it as how many sites on an artery were treated, it's actually how many arteries now. So there's a move from sites to arteries, and I'll show you an example that will make it a little more clear. So for example, if multiple arteries are bypassed, a separate procedure code for each artery is used and the number of devices. So if, for example, if an aortocoronary artery bypass and internal memory coronary bypass are coded separately. There's a big change now with control. So doing audits originally, some coders, some clients were making a mistake of coding control for any bleed. And actually it's not the case. It wasn't the case before, where the only time to use the root operation control was for, this was only for post-procedural bleeding. Now they added that you can use control for any other acute bleeding. So this makes a lot of sense to add this, because it didn't work before, where it would go to a surgical DRG for a very simple control of a bleed, very simple cauterization. So now they added the very important language of or other acute bleeding. So anytime there's a GI bleed and it's controlled, now it's correct to use control. The only exception is if, for example, shown here, if there's a resection of the spleen to stop the bleeding, then it's coded as resection instead of control, because actually the larger procedure, the more significant is the actual resection. It happens to be controlling the bleeding as well, but that resection is really what the root operation should be. So here's the example. I want to give you more clarity on how to use these multiple artery codes. So at the top is the 2016 guidelines, and the bottom is 2017 guidelines. So instead of saying sites, we're talking about arteries. So one procedure code specifying multiple arteries is used when the same procedure is performed, including the same device and qualifier values. So really you got to look at how many arteries are treated as opposed to the sites on that artery. So if 2 stents are put on one artery, you would code the one artery plus 2 stents as opposed to 2 sites on a single artery. So the example they give, say there's an angioplasty on 2 distinct arteries with placement of 2 stents is coded as dilation of coronary artery, 2 arteries with 2 intraluminal devices. So you have to first think how many arteries are treated and then how many devices are put on those arteries. That's what you have to focus on, as opposed to how many sites on one artery or 2 arteries. Just think about number of arteries and then number of devices, not this idea of sites. It's really the same thing in terms of thinking about it, but just the language is different and the coding is slightly different, but the concept is the same. You know, no matter what, you have to know how many arteries are treated, how many devices or stents are put in, and now instead of just saying sites, you talk about arteries. So is it one artery with 2 stents put on it, or 2 arteries and 2 stents? Before, if it was one site, it was one artery with 2 sites, it was unnecessary to even say, well, how many sites? Really, we want to be thinking about how many arteries and how many devices were put on those arteries. So just to give you an example, if we were to compare 2016 to 2017, before, if we had an angioplasty placement of 2 drug-eluting stents in the left anterior descending coronary artery, how would you code that? In 2016, you would code it as dilation of coronary artery 2 sites with drug-eluting intraluminal device. In 2017, since October 1st, to be coding it as dilation of one coronary artery because it's the left anterior descending with 2 drug-eluting stents percutaneous approaches. Percutaneous approach. So now it's a focus on how many arteries, how many stents, as opposed to how many sites and then with a stent. I think this way it's actually more precise because it tells you how many actual stents are put in as opposed to sites. So moving over to the key changes in a coding clinic, many of the coding clinic changes were included in October 1st, but there are some I wanted to highlight that I didn't go over yet in October 1st changes. All right, so the very biggest one, this is a major change, is diabetes and complications. So before, they actually said that osteomyelitis could not be linked or automatically assumed to be due to diabetes, but they changed that in the fourth quarter 2016. They said anything listed underneath as with diabetes would be coded as due to diabetes. This is a huge change because there would be times where the doctor would write, say, diabetes, and right underneath it, they would write gastroparesis. And we would have to query and say, is this diabetic gastroparesis or is this gastroparesis due to diabetes? It always seemed a little bizarre where the clinical picture supported that this patient had diabetes, then developed gastroparesis, so of course it would be related or likely related to the diabetes. But we always had to query. But now with the new guideline, you almost don't have to query for anything. Looking through the list, pretty much the most common diabetic complications are automatically linked, and now including osteomyelitis, which they corrected. So looking at it, just the major complications, CKD, circulatory, foot ulcers, gangrene, gastroparesis, nephropathy, neuropathy, and so on, skin ulcers, all automatically assumed to be due to diabetes. This is a major change from ICD-9 and also recently with ICD-10, where gangrene was always assumed, but we couldn't assume, say, gastroparesis that I mentioned or peripheral vascular disease. Now these are all included. Circulatory complication, that's where peripheral vascular disease would go. These all assumed to be diabetes. In the inpatient setting, usually it's documented pretty well, but outpatient, usually it's not. So now this will be a major change for outpatient coding because we can make an assumption between diabetes and complications. So the only exception is if a doctor actually says there is another cause of the complication. So say osteomyelitis is unrelated to diabetes, say it's related to peripheral vascular disease, which is not related to diabetes, then you can code it separately. But again, once now everything is assumed, it'd be very difficult to unlink diabetes unless the doctor explicitly says that a condition is not related to diabetes. Another major change that happened in the second quarter of Coding Clinic was that before, coding the arterial line would actually change the DRG, and that was a very big finding for all our auditors because previously insertion of an arterial line or A line would not be a surgical DRG. So now they have corrected this. So the insertion and monitoring of arterial pressure was, if it was coded prior to October 1st, it would actually change the DRG. So just to show you side by side, prior to October 1st, coding the intravascular pressure measurement of peripheral arteries in ICD-9 would actually not be an MCC, but then you see on the it would not be a procedure, but then on ICD-10, adding those codes would actually convert it to 981 extensive OR procedure. So now this is not the case. Previous October 1st, this was the case. After October 1st, now it's not. So now they've what they call a replication issue between the DRGs. Now they've corrected it. ICD-9, it wasn't a surgical DRG, and then it was. So now they've corrected it as you'd expect, as they're continuing to make these changes to the DRG mapping. Same thing happened with HoB Laceration Repair. This was also another what we call a replication issue where it should not be a surgical DRG, but because they didn't make any major changes to ICD-10 until October 1st of this year, now they've corrected this. Also to mention that there's new codes for hepatic encephalopathy, just to be aware of. So just look out for very specific documentation to make sure you get the right code. Now it's with or and without coma, so that was corrected. So just the final thing just wanted to review was this controversial clinical validation. This idea that really in a nutshell that the coding clinic and the cooperating parties are saying that coders must code what is documented in the record. And there's no clinical criteria per se. If a doctor writes a condition, then you should code it. That's really the basis of the argument. But of course, there are exceptions to this, and they're really this new clinical criteria doesn't really change. It's not really a total game changer, but I think it's just adding clarity to the idea that if a doctor documents, then you should code it. I think that's what they're really saying. It's not within the scope of coders to question clinically what a doctor is documenting. But it is expected of coders to code only what is concise, consistent, clear. So there's this kind of back and forth there, I see. But in the end, I don't think it changes anything. I think we always code what is supported by documentation. What it comes down to is what's your interpretation of being supported. So I would just just to talk less in abstract and just think about examples. If a doctor writes hyponatremia, and typically a sodium below, say, 131 would be considered hyponatremia. What if a doctor writes hyponatremia and it's 132 or 133, where most providers that I've spoken to at least wouldn't really be concerned with sodium until it hits 131 or below. So definitely like 129 or 128. But if a doctor insists that a sodium of 132 for this patient or a particular patient is hyponatremia, then it's not acceptable for coders to question that. So I think that's what this clinical validation is trying to address. We're saying if a physician documents it and it's strongly documented, it's consistent, say it's on a discharge summary and progress notes, then you really don't have grounds to question that as a coder. But insurance companies do. Insurance companies can question whatever they want, and they do. So those need to be handled on a case-by-case basis between the provider and also the insurance companies. So that's where you have to be very cognizant and very consistent with how coding is done. So when things come, for different examples, say like sepsis, where if a doctor documents sepsis once in the chart and there's nowhere in the chart that really supports it, and it's only written once, then coders are actually allowed to not so much question that, but ask for clarity by the physician. So that doesn't change anything. If sepsis is only written once, then you wouldn't question the doctor, and you wouldn't necessarily just code it by itself. You would clarify it and say, could you please document it again or include it in discharge summary? So this, again, doesn't change anything. This is what has always been done. But I think they're finally addressing the fact that coders are supposed to code what's in the record, but if there's any question as to the support of that diagnosis, then you would query. So this really doesn't change anything, but I think it gives some support if an insurance company were to say, well, the sodium is not below 133 or 131, so we're not going to accept that code. I think this coding clinic would help and say, well, per coding clinic, we are supposed to code what is documented. And if a physician feels that that's hyponatremia, then we are not here to question that. So I think on some cases that could be very helpful, but for other cases where, say, sepsis is written just once, then, insurance company probably wouldn't take that in the first place. And second, the coding department should ask for additional documentation for consistency. So I think this helps in some scenarios, but for the most part, I really think that this doesn't change the majority of the queries that are already going out. So just wanted to just give our take on this clinical validation and all this discussion around it. So that concludes our this recording, And if you have any questions, my email's right there. It's bsayababorn@providentedge.com. I thank you for listening, and I look forward to for you joining in the future webinars and for the coding webinar series. Thanks.